Welcome everybody to our event today, Enterprise in Health, who are the innovators. I am Josefine Magnusson. I am the Senior Research Officer at Future Care Capital, and I will be talking you through our most recent report today on enterprise in health and the involvement of clinicians and academics in these kind of enterprises. Future Care Capital, for those who don't know, is a charity that dates back over 70 years, and we have Her Majesty the Queen as our royal patron. Our vision is to see all of those in receipt of care benefit from a functioning and fit-for-purpose health and care system. In that respect, we focus particularly on data, technology, and innovation as it relates to health and care. And we work with and influence policymakers through our research, health and care practitioners and other stakeholders, bringing together people across the spectrum in conversations and debate around health and care. We also put our money where our mouth is, so to speak, and invest and partner for social care impact. The event today is going to take the form. I'm going to take you through the report that we published last week. We're then going to move on to a panel debate, and I am very pleased to welcome our panelists today, Dr. Claire Bloom from NCME in Oxford and Catherine Pollard from NHSX. And I will briefly introduce the speakers to you now before we moving on to the presentation. So Catherine is the director of the Centre for Improving Data Collaboration at NHSX. During COVID-19, she has led NHSX efforts to use technology to accelerate the integration of health and social care. And this draws on her prior experience as the Executive Programme Director for an SCP and as Policy Director at NHS Improvement. She's an experienced healthcare professional and has also led work on provider digitisation, radical redesign of care pathways, financial recovery and capacity building. Catherine is inspired by how data and new technologies can promote independence and person-centred care and or address the multifaceted workforce challenges that the sector faces. Dr. Claire Bloomfield is the CEO of world-leading consortium of artificial intelligent medical imaging, also known as NCME, at the University of Oxford. NCME is Oxford's new and revolutionary launchpad to improve the healthcare industry through the use of AI. The NCME consortium is led from the university, whereas Claire is successfully managing partnerships with 14 NHS hospitals, clinical leaders, industry experts, academic researchers, patient groups, and philanthropic organizations. Claire's own research has been focused on neuroscience, and she has held research fellowships at Oxford University and the University of Maryland School of Medicine. Following her academic research career and before becoming the CEO of the NCME consortium, Claire returned to Oxford as the Head of Strategy and Innovation for Cancer Research UK Centre. Claire's role placed her as a nexus of cancer activity within the university community and the UK overall, affording unique opportunities to work across cross-departmental and pan-divisional projects, resulting in raising more than £250 million to further UK cancer research. Claire's particular interest is in imaging, and AI focuses on supporting the ecosystem to develop effective collaborations that generate value for all our stakeholders and ensuring equity and diversity in both the development and application of healthcare AI. So as you can hear, we have two eminently competent and very experienced speakers, very well placed to speak to this, speak to the agenda today. So if I can have the first slide of the presentation, please. So the background to this work is that we have previously at Future Care Capital undertaken work that investigated the demand for healthcare data as held by NHS trusts in England. And through that work, we found that such demand tended to be greater for data held by trusts that were located in proximate to a Russell Group university, and that the larger numbers of requests for data came from higher education institutions themselves. However, notably in the previous research we did, we received only very limited information from the Shelford Group trusts, which comprises 10 of the largest teaching and research hospitals in England. So the research that we are presenting here today is going to focus a bit more on those trusts and those associated universities to find out a bit more about enterprise activity within those. To put the research in context, in the autumn of in 2020, the Chancellor of the Exchequer announced plans to increase R&D investment in the UK to 22 billion per annum by 2024-25. And this pledge reflects the government's commitment set out in its research and development roadmap to make the UK a science superpower and a more attractive place for entrepreneurs to invest and operate. They've also established a number of strategies and initiatives to support this vision. For example, the Life Sciences Industrial Strategy, the Academic Health Science Networks, Innovation Exchange, and Accelerated Access Collaboratives. And the aim of the AHSNs, the Academic Health Science Networks, is to bring together health services with academics and industry in order to encourage innovation that will bring tangible benefits to both the economy and to patients. And it's this collaboration between all the different sectors of the health enterprise landscape that has inspired some of the research that we are going to talk you through today. Following that, the Innovation Exchange is assisting that process by identifying innovations with the greatest potential to improve practice and patient outcomes. And the Accelerated Access Collaborative provides further support in getting the best products to market quickly. So this whole ecosystem is really set up to bring about, to ensure that the UK can become a science superpower and drive this innovation forward. Can I have the next slide, please? So the remit of the AHSN was renewed in 2019 and funding was guaranteed to 2023, provided that the networks achieved success in spreading proven innovation across the country. This points to another goal in nurturing healthcare innovation, which is to ensure that benefits are spread evenly across the country, and it fits in with the government's general levelling up agenda. So to this end, it is interesting to note which institutions, both NHS Trust and academic institutions, stand to benefit from these kind of collaborations and from health enterprise in general. And it also brings up questions about transparency, about involvement at the individual level. And this is something that has also been taken up in the Cumberledge Review, which was published last year, which is called First Do No Harm, and which is looking at how interest of particularly clinicians in this space might impact on patient trust. For example, transparency over the extent to which clinicians are involved in enterprise activities and the development of products and treatments that they may then suggest and recommend to patients. Can I have the next slide, please? So what we did in our research here to try and bring this all together is that we were looking at particularly at academics working in pertinent departments in Russell Group universities and associated research centres. And those departments were departments linked to medicine, engineering, biology, chemistry, and some maths department if they had relevant AI research going on. And through identifying staff working in these departments of university staff lists, we found 18,825 potential university staff. For clinicians, we used the registry of the General Medical Council, and we were focusing particularly on clinicians that are working in NHS trusts linked to the Russell Group universities, either in proximity to Russell Group universities or having known research and collaborative links with those universities. We focused on clinicians working in England only and only in the NHS, so no private practitioners. We used these two lists of academic staff and clinicians to match to Companies House records. And particularly we used the records within Companies House of persons with significant control. And people who are listed as person with significant control on Companies House are likely to have a majority or a significant proportion of shares in a company, and they have elevated powers in terms of making decisions and board decisions within a company. So we're focusing on those people in particular. And once we had linked the two lists of our individuals against records of Companies House, we performed a number of cleaning activities to make sure that we removed incorrect matches and duplicates and private medical companies, because we were only really interested in finding out which individuals were linked to innovative companies that were not providing clinical services as such, but who were producing treatments or products for healthcare. Can I have the next slide, please? So first of all, we were looking at gender to see whether there was a difference between men and women among the clinicians and academics that we list to with regards to having companies. And we found a quite large difference. So among clinicians, about 80% of the companies that we identified were linked to male clinicians, only 20% female. And among the academics, that split was even more stark. So we had 90% of the companies linked to academics were linked to male academics and only 10% to female. We know from looking at the GMC list that the split between men and women in the original list was fairly even. So there's definitely an underrepresentation of women in here, even looking at the original sample. And the same goes for academics, looking at the proportion and spread of men and women working in these areas in England as a whole. Can I have the next slide, please? With regards to age, we found that the average age of the clinicians and academics linked to companies was 49 in both samples. This is slightly higher than what is found in other research. So other research tends to point to the average age of entrepreneurs to be in their early 40s. So it seems that our sample is slightly older than what might be expected. We also found that there was a greater spread of age among the academics and among the clinicians. So for example, both the very youngest age groups and the very oldest age group, we had more academics who were involved with companies than we did clinicians. And this might reflect the overall sort of trajectory of an academic versus a clinician. So it takes longer to qualify as a clinician. So therefore, it would make sense that you wouldn't have a lot of people in the very young age brackets who are starting up companies. And similarly, we also know that academics tend to stay on working for beyond retirement in quite a significant proportion of cases. So therefore, it also makes sense to have a slightly larger proportion among the older age group. Can I have the next slide, please? So we also looked at the particular specialties that were linked with companies. And we found among the clinicians that there were some of the bit more smaller and more niche specialties that tended to have a higher proportion of people working within them who were also linked to companies. So we have otolaryngology, for example. That's the most entrepreneurial discipline among clinicians, if you like. Then we have trauma and emergency medicine, and we also have urology as the third most frequently noted discipline within these. And it may be that there is something about these particular specialties that lends themselves particularly well to innovation, or it might be that the people working within these sectors have better conditions in which to set up companies for whatever reason. And this is something that we want to explore further. And if we're looking at similarly at the academics, if we go to the next slide, please. The disciplines that we found among academics that tended to have the most people linked to companies were overwhelmingly engineering, and that includes bioengineering, computer science, and also medicine. And we have hypothesized that it might be that these particular disciplines, both among clinicians and among academics, are more likely to lend themselves to innovation that's related to technology and to medtech, to AI, rather than the more traditional type of medical companies like pharmaceuticals, for example, because this is something that that we noted to some extent in the types of companies that we found. Can I have the next slide, please? So we tried to work out what types of companies we had in our sample, and the Companies House lists the activities of the companies that they have with particular codes. So you can, in theory at least, you can try and work out what a company does based on the code. What we found, however, is that the by far most common codes for the companies in our samples were very generic. So we had, for example, specialist medical practice activities, general medical practice activities, and other human health activities. And all of those together took up about 3/4 of the sample. And this doesn't tell us very much in detail about what activities the companies actually undertake. We did do some going in and drawing out a smaller sample of companies and just try and work out what was there. And we found that we had indeed identified more companies, it seems, that are related to technology, to artificial intelligence, and to AI in the health space, rather than the sort of pharmaceutical discoveries. And this probably makes sense because pharmaceutical discoveries is often done in collaboration with already established pharmaceutical companies, where clinicians and academics work in collaboration with such, and so they wouldn't necessarily be set up to be have a prominent role within those companies themselves. Can I have a next slide, please? We also try to look a little bit about at the value of the companies that we have identified. This can be done through the public accounts that are submitted to Companies House and which we had access to. What we did find, however, is that only about half of our sample, particularly among the clinicians, had machine-readable accounts. And for the size of the sample that we had, machine-readable accounts was pretty much a necessity for being able to say something meaningful about this. So the financial analysis that we have undertaken is relating to a subsample of our larger sample overall. We wanted to find out a little bit about where the highest concentration of profitable companies were located. So this is what this slide shows, and it shows the NHS trusts where the highest proportion, or where the highest value companies were located. We are a little bit cautious about this because it could be that there are certain very high value companies that drive up the average value in these particular trusts that we have in the top 3, because we only identified a relatively small number of companies linked to these trusts. But what I will draw your attention to is that the 4th one on our list here in NHS Trust in terms of value of company is Imperial College London, which we will also see if we go to the next slide, is in the top 3 of the universities that we were looking at. So while the other centres, NHS Trust, universities, didn't show too much overlap in terms of value of companies, for Imperial, they appeared in sort of the top range of high value companies among both NHS Trust and among universities. Go to the next slide, please. So this potentially indicates maybe not a lack of collaboration, but certainly a lack of overlap in our 2 samples, which is something that we found in relation to other areas as well. So the only NHS trust and university that significantly seems to have an overlap with regards to value and other indicators was Imperial. And this collaboration between different aspects of the ecosystem, of course, is a priority of the AHSNs, the Academic Health Science Networks. So while we don't see our data as being conclusive, I think there is certainly some additional things that you could look at in this space to see how these collaborations function in practice. Go to the next slide, please. So the conclusions we are drawing from this is that, first of all, that identifying clinicians and academics who are involved in health innovation is very challenging because of the steps that were needed to undertake. So you need to have access to the list of individuals, you need to be able to match them. And because of the lack of information, both on the General Medical Council register, for example, and with companies' house data, this can be quite challenging to do. We also found that the health innovation landscape is heavily male-dominated, with 80 to 90% of the companies that we found being linked to men. Companies operating in data and technology appear to be far more readily identifiable using the technique that we were using, rather than companies linked to pharmaceutical discovery and manufacture. What we also found was that, and this echoes some of the findings of our previous work, is that acute trusts among NHS trusts appear to be linked to significantly greater involvement in health enterprise than trusts that are mental health trusts, community trusts, or ambulance trusts. And this looks like it is a trend across some of the work that we are doing. And finally, we could identify only very limited geographical overlap between the two sectors of universities and NHS trusts, despite the highlighted need for a collaboration between different aspects of the R&D ecosystem. Next slide, please. So finally, to go on to our recommendations. Based on our findings, we recommend that there be means for an appropriate body to have access to information about financial interests of clinicians from the point of view of patient safety, even if that information isn't made publicly available, in order to protect privacy. And this information could be linked to the General Medical Council register. We also recommend that the AHSN extends its current focus on diversity to put greater emphasis on what can be done to encourage and support women to get involved in health enterprise. And for universities, this might be considered under the Athena Swan Charter, which is specifically focused on addressing gender inequalities. We also recommend that further work is undertaken to compare our findings, which focus particularly on centres of excellence, and to compare that against activities in less prolific and research-intense trusts and universities, to assess the performance of support for enterprise and innovation for the government's levelling up agenda, and to see where there may be lacking and where there may be barriers to this kind of involvement. And that takes us to the end of our presentation. So I'm going to open up, start up with some of the questions, and I will say to both Claire and Catherine, welcome and thank you for being here again. I did do your bios earlier, but if there's anything that you would want to add as you answer the questions about your work and about the centres that you operate in, then you're very welcome to do so, feel free. So I'm going to start up with, in our report, we have called for greater transparency with regards to the involvement of both academics and perhaps especially clinicians in health enterprise and profit-making companies. And I'm going to go to Catherine first. Your team are responsible for growing the number of data collaborations. So to what extent are you prioritizing transparency, both from the point of view of building public trust in how data is used, but also from the point of view of ensuring that you really have a view of what is happening and understand the differences that the department has made?
Thank you, Josefine, and thank you for a fascinating presentation. There was a number of points in that well, hopefully that we'll be able to pick up on. But the question of transparency is, as you say, one kind of close to our heart. So the Centre for Improving Data Collaboration, which is part of actually the government's response to the Life Sciences Industrial Strategy, has 5 principles that are meant to guide the way that data-driven partnerships are undertaken between NHS bodies working in collaboration with industry, of which one of those principles is around transparency. We've also, the centre's only been in existence for about 6 months, and so we have also been undertaking some of our own research about what practice is currently undertaken when this is when corporate NHS bodies are working in partnership with industry, so rather than individuals. And we're definitely finding that there's a significant amount of variation in this space, and that in some circumstances there's a high level of patient engagement and participation in some of these decisions, and in other instances less so. And in particular, we've come across some quite restrictively worded NDAs in use. And so this is something that we are thinking about very actively at the moment. So how can we respect some of the commercial confidence that needs to be protected, particularly around some contract values and things like that, but actually we need to be much more transparent with the public and patients about the work we're doing in partnership, and so exactly what that is going to take shape as something we're thinking very actively about over the coming months, and I think we'll probably end up iterating. So we'll start with some suggestions, highlighting good practice, and then hope to nudge the sector into a more transparent way of working. I would probably, in terms of the specific recommendation that you make around the linking with the GMC register, I would probably actually defer to the view of a clinician like Claire, and to see whether she thinks that would work. I'd want to think through some of the potential consequences of something like that and make sure that they were fully thought through.
Thanks, Catherine. I will put that to Claire then to follow up, and also asking Claire, you're working sort of in the intersection to some extent between clinicians, between academics, and between enterprising entities. So how do you feel about the transparency issues and implications based on your experiences in this role?
Thanks, Josephine. And again, I'll just reiterate Catherine's point. Congratulations on the content of this. I think it highlights some gaps in our national understanding of this, which you can have insights on a more local level, but how does that scale in terms of awareness more across the UK? I'm not actually a clinician, so I'm an academic by background, but I've spent the last 20 odd years almost working around clinicians, particularly in the Oxford ecosystem. And so my observations would really be about the fact that we see the same individuals wearing multiple hats, and there's been a big push on clinicians to become more academic and to engage more, and we've seen the training of clinicians evolve to try and support more innovation and flow between academic institutions and the NHS. And likewise, we're seeing the demand placed on clinicians to then innovate and see how that scales into companies. So we, at least within Oxford and NCME, see the same individuals wearing those three hats, and it can sometimes be very challenging to record those three hats and to which role those individuals are placing when they're engaging in certain interactions. I would hope clinicians would be open and welcome the opportunity to categorise some of this. We work hard locally to manage conflicts of interest and record those within the work we're doing. But I think I can't think of a good reason why you wouldn't be able to flag some of these affiliations as part of the GMC register. And some of these are apparent to me in terms of directorship roles rather than person of significant control. So again, helping define what roles we're interested in and what roles we think might have influence that therefore need to be recorded. And I'd encourage the inclusion of directorship of companies in that, as well as PSC functions. But yeah, not a clinician. I've been an academic. We certainly, I think, as I say, there's a role for conflict of interest management, but recognizing that is complex because we want people to innovate and you want to see innovation move through those different parts of the ecosystem. And that's often best done by people straddling the different domains.
Thank you. I'm going to stay with you, Claire. So our report has focused predominantly on centres of excellence, and you represent one of those at Oxford. So how do you see the role of Oxford, and perhaps more specifically NCME in your case, in data deals and collaborations? What are the benefits of being a centre of excellence in this space?
I think so. NCME is fortunate that it's a partnership between 14 NHS trusts across the length and breadth of the country, combined with a hub of expertise. So we try again to straddle both. I think there's an important role in having areas of focus where you can invest deeply in expertise and ensure you're really driving new R&D and innovation. But there's also a responsibility to scale that and ensure deployment across the country. And we really look to balance both. So we're very interested in ensuring that we're taking the different perspectives from Glasgow, Newcastle, Leeds, Truro into the way we're designing AI solutions and then the way we're deploying those, not only to ensure that we generate diverse data sets that drive scalable and valuable AI solutions that will deploy at scale, but also to then make sure we're incorporating the different perspectives of those groups and the clinical expertise that those groups have as well. The whole system has an important role to play. So there is incredible value in the experiences of district general hospitals in deploying technology and innovation and how it works in clinical practice that can often be done at greater speed and efficiency than it can in a large academic teaching hospital where there are a number of potential priorities and so much innovation that it can be challenging to get your solution deployed. So there's a balance between depth and breadth, and hopefully activities like NCME support both so you can harness the expertise and the collaboration and then scale that nationally.
Thanks, Claire. And building on that, I'm going to ask the same of Catherine, but I'm also thinking, so our work has previously found a disparity in the spread of data deals. So they tend to be more concentrated in certain areas. So Catherine, do you think the government should, in the spirit of levelling up, invest in areas that have previously not had the skills and capacity or experience of these types of collaborations? Or do you think that it makes sense simply to build on the excellence and success that is already there?
So I think that in the goal of levelling up is got to be the right one, and that we need to be cognizant of the capability challenges that exist kind of across the country. I would say that actually it's very rare, even within the larger institutions, to have kind of really strong in-house legal and commercial expertise that you'd want, and that probably only 2 or 3 trusts in the country really have that expertise. So it's not quite a kind of clear cut the haves and has not. And some smaller trusts, as Claire has already said, are actually highly innovative. So I think kind of rather than necessarily saying it's the ones linked to the academic institutions and everyone else, there is definitely disparity. We think it's really important for both the diversity and inclusion agenda from a data representation perspective, as well as from making sure that the kind of benefits from any kind of economic growth and innovation is spread evenly across the country, that these are addressed. But I think doing so is going to require a number of different interventions, some of which I think is going to be about encouraging collaboration, so encouraging projects like NCME, which is a network of, as Claire said, there's more than a dozen trusts across the country. And we'd hope that some of the work on integrated care systems and what were the LICAs, so the shared care record, which kind of operate at regional level, will enable some of that capacity and capability to be built rather than in whatever it is, 200 plus institutions in a smaller number, because some of this expertise is really quite difficult to attain, and also there are significant economies of scale. I think the other thing that we'll want to think about is how we can evolve some of the policies that mean that there is recognition of the work that goes in to collect the data, and that there is a kind of sense of you've contributed something, and therefore you're part of the kind of the benefits agenda, which is sometimes the case and sometimes not the case, as we've kind of dug into this a bit more. And then the final thing I'd say is that we need to think about how we promote more diversity and inclusion in all aspects of this. So some of it's about the data, and some of it's about the geographical spread, and some of it, I think, as Claire has kind of already noted, is also about, and you've noted in your report, is about the kind of gender and ethnic makeup of some of the people working in this space. And I feel like all three are really important agendas that we need to put our policy thinking hats on and work out how we can address address and try and start to promote reduced inequalities?
Yeah, I'm going to pick up on that a little bit more, actually, because obviously one of the very stark findings in our report is the gender imbalance between the people that we identified. And by pure coincidence, actually, we're talking now during Women's History Month, and we have a lot in the news at the moment around gender issues. So this kind of fits in very nicely to that. And also, as it happens, we have an all-female lineup today, which is kind of, in a way, a nice counterbalance balance to this. But starting off, did these figures surprise you? I'll start with Catherine.
Yes, they did surprise me about how stark it is. And then I went back and thought about the innovators that I've worked with and encountered over the course of the kind of, the handful of years that I've been working in the health tech agenda. And then I was somewhat less surprised. So probably it's kind of, they're shocking because they're not right. But actually then when you cross-check your empirical experience, you're like, actually, yep, most of the people that I have come across and who kind of reached out, tend to not be female. And that's something, that concerns me deeply.
Yeah, and why do you think that it is that women are still so underrepresented in this space?
Oh, that one is it's a tricky one.
I think that's a really tough question to ask on just this topic.
Yeah, I mean, to some extent, I feel like it's going to be a mixture of motivation and support, and also role models, and I guess also specifically about the extent to which some of the support we've given for innovators is sufficiently nuanced in how it encourages women who might not be the kind of traditional dragon's den, I'm going to pitch my idea, I'm going to go at this kind of relentlessly. And so I think there's a number of different things. We're actually working quite closely with the Accelerated Access Collaborative and then Clinical Entrepreneur Program to think through how we can support more diversity, actually both ethnic and gender diversity in their entrepreneur program. And they've done a lot of interesting engagement with innovators about the way that the style in which things are done, and particularly some of the kind of more aggressive kind of pitch making that's traditional to kind of entrepreneurship, and the extent to which that can be quite intimidating. And I know that for the first set of applicants they did for their round this year, they did a completely blind paper-based review of the expressions of interest to be a clinical entrepreneur, and their numbers of the diversity of their participation for this cohort is much improved. And so I think your point around really getting the AHSNs to be very focused on this feels important. Claire, I'm sure you've got a perspective from your experience.
Yeah, thanks, Catherine. And so a couple of observations I'd make is it was even worse in the academic than it was in the clinical cohort. So there's an interesting piece of why are female clinicians feeling more able to engage in innovation and entrepreneurship than academics are. My gut says there may be something in the sense of you have a safety net of the day job, of you have your clinical career, which can make you slightly more able to take risks because you have a solid base, whereas academic careers by their nature can be less sure-footed over the longer term. So taking that higher risk to engage in something that can pull you away from your academic success is one I think is worth exploring. I'd say the University of Oxford has been trying to tackle some of this recently. There's been some great work with the Oxford Foundry, which is looking at student-led innovation, which I think is embedding this into earlier stages of people's careers. And also there's a very new program called IDEA, which is around trying to support more women entrepreneurship in Oxfordshire. So not tied just to the university, which is showcasing a lot of women who have succeeded, who are making it, who are female CEOs, to try and highlight and showcase more role models, which Catherine mentioned as being important. So I think there are pilots of how this is being approached, but I think thinking about how you support entrepreneurship in academia it certainly wasn't something I particularly thought about 20 years ago when I was doing my PhD, was where was I going to take this in terms of a commercializable route. I think things have changed a lot since I was doing my DPhil, but there is still scope for how do you highlight, promote, showcase and support individuals in progressing. But it's not just healthcare, and it's not just the university and clinical ecosystem. We know that AI companies are only 20% women in leadership posts. So this is broader than just health and academia, but it's something that we should be addressing, because we know that has an important role to play in then generating solutions that are diverse and do support the range of patients you need to be considering. And there was a publication out recently that looked at emotional intelligence and more EQ skills and the need for those in entrepreneurship. So how we can better value and recognize the important contributions of skills often associated with women as being really valuable for entrepreneurship, rather than assuming women are not a good fit for running and starting up new companies. So there's a whole dialogue about how we shape that more and showcase more examples and provide the evidence of how actually it's not something that's a positive discrimination, but actually has direct commercial and other types of value by being more inclusive. So I'd hope we see more of it.
Yeah, and actually, just to build on Claire's point, if I may, Josephine, is I think there is good evidence that having a very diverse board and having more women on boards, both at the more mature organizational level, leads to better commercial success long term. And I know that there is a kind of growingly and increasingly vocal cadre of female investors that I think are really trying to spread that agenda. But like I said, I think this is going to be multifaceted, and one that needs to have bottom-up, grassroots-led initiatives, as well as things that we can do, from the centre in terms of policy.
Yeah, absolutely. Thank you. The other thing I wanted to ask about is we're living in a very peculiar context at the moment with the pandemic and all the kind of implications that have. And I think we've seen in some areas that this kind of emergency situation has led to particular innovations and particular things being developed in response to that very rapidly. But I wonder if you're sort of thinking more broadly, have you seen a particular impact of the COVID pandemic in terms of how innovation is happening and what implications that has for starting up companies or being entrepreneurial as such? I put that to Claire first, I think.
So the short answer is yes, we absolutely have done. I think it's incredibly powerful where there is a common goal. So the pandemic created a unity of purpose, which helps drive innovation because you're trying to tackle the same problem. How that works post-pandemic, when everybody starts to refocus back again on the multitude of challenges we face and still retain that drive and innovation, I think is an interesting one to balance. Within the pandemic, obviously, there's been direct COVID-related responses. I could list the Oxford ones for you, but I won't. I think the audience probably are well aware. What I would pick up, and is a direct, closer experience through NCME, has been one of our partners, Brainomics, who has an e-stroke, so an electronic stroke suite support solution, which was already beginning to be deployed across the NHS, but massively ramped up in terms of its deployment and the uptake by NHS Trust, because it allowed stroke clinicians to work remotely and engage with reviewing scans, triaging patients, and ensuring they got to where they needed to be in the system, which was really valuable in the very early stages of the pandemic, where you were trying to restrict who was coming to hospital, both clinical teams and patients, but also triaging those to be where they needed to be. There was a sense of aligning to get things done in terms of what can often be bureaucracy around process that can slow these innovations down in terms of deployment. I think that's something I've been particularly pleased to see, is how the ecosystem has come together to go, how do we do this quicker, because we've got a very acute problem to respond to. There's a need to rebalance, so there's checks and balances still, and there's a need to ensure that we're not breaking all the rules, but we've been bending and following rules and process as we can do. But that would be a specific real world example where we've seen regions deploying new AI tech during the pandemic that I think would have been a lot slower without that acute need.
Thanks, Claire. And Catherine, from your position within NHSX, how does this what does this mean for government and for future strategy in terms of supporting innovation in this space?
Yeah, I mean, well, it's a big question, and I think probably one that NHSX, like all of us, are trying to get our heads around how we can kind of harness the momentum that we've seen in digital transformation, and that includes both innovation, the use of data, the use of digital platforms and digital communication channels. So many things have changed in the last year, and really the challenge is about how we maintain momentum. We do, as Claire say, kind of encourage that right balance between experimentation and iteration, as well as the right checks and balances around kind of safety, and also how we recognize kind of some of the workforce implications of this, which I think are, quite considerable. So some of the things that we're thinking about at the moment. So as kind of listeners will be very well aware, we are like the NHS. Once we step down out of our kind of COVID response phase, we've got a very significant amount of recovery to undertake. We have a lot of patients on our waiting lists. And there are already some examples of trusts, like those of like Birmingham, who are thinking about using AI. At the moment, they're doing it in a very much in a kind of pilot and an experimentation mode. It's not part of mainstream clinical practice, but they're thinking about using AI in dermatology, AI in ophthalmology, as well as kind of some of the more advanced triage tools in their emergency department, to think about how they can ensure that they are treating the patients as close to home as possible, and making best use to some of the tools available to support the workforce who are very challenged. Similarly, there is examples in Hampshire and other parts of the country thinking about, we've established COVID virtual wards really well, so how we monitor patients who've got COVID at home. How do we use some of that technology around remote monitoring? Again, we've got lots of people with long-term conditions. It's ideal if they're never in hospital. What can we do in homes, in care homes, to make sure that there is that, digital safety net and enable people to be cared for safely in their homes. And then the other thing as well is kind of thinking about the collaboration. So as Claire said, like there was a huge commonality of purpose during the COVID pandemic, and there has been some collaborations across teams and across organizations that has hitherto been quite difficult. And again, I think technology's got a real opportunity to be a platform that can enable that collaboration and that MDT working. And obviously data is going to be underpinning lots and lots of these. And so another big thing we need to do is work out how we can the COBE notices have been very helpful in terms of smoothing a lot of the information governance requirements around sharing of data in relation to the pandemic. So we're doing some work on what we need to do to ensure that sharing where it is in for the benefits of patients and the population is continues to be promoted. So that's a flavour, but effectively you've just described what NHSX is trying to do for at least the next year, if not the next few years.
Thanks, Catherine. And maybe put that back to Claire as well. If you're thinking about the immediate future or the future over the next few years, what do you see as the priorities in this space in health enterprise for the coming up? Thinking about the work that you are doing with NCME, are there particular gaps or particular areas where you think needs more?
So I think there was a feeling, particularly in the medical imaging space, that AI offered a real opportunity pre-pandemic, and there were workforce shortages. We know that those have increased. We're looking at sort of 43% regionally in the north around radiology workforce shortages. There are AI solutions in the pipeline trying to tackle those ongoing challenges. One area I think NCME is now trying to focus is how do we speed up the last mile component? So there are plenty of companies generating exciting innovation. How do we make sure that we're generating the evidence base across real world data sets, that those are scalable, they will work in clinical practice? Even if CE marked and regulated, how can we validate those and assess those in diverse hospitals to ensure those will then stand up when they're deployed. So that's one thing I think we're focused on, is how do we speed up and support that process so you can get great solutions into the hands of clinical teams quicker. And then on a more an R&D side, which I'm quite excited about, is our new program linked to the lung health check program nationally. So looking about how we've embedded data research and AI into that lung screening program from the outset. So to ensure that we're gathering the data prospectively throughout that 150,000 patient cohort across low dose CT, clinical records, blood-based biomarkers, digital pathology, and integrating that to generate new radiomics, so multimodal AI solutions that could have the potential to remove the need for surgical biopsy for lung cancer, full stop. That's incredibly exciting and looks like you're going to transform clinical pathways completely. That will take more time, obviously, because it's a 3 to 5 year pipeline to get that through. So it's a balance of how do we speed up what's close to clinicians to get it there faster, particularly, again, as Catherine alluded to, the workforce have been stretched in the pandemic, and we need to be caring about the way we support them in delivering care. So keep the innovation engine going and provide more solutions with as little burden on them as possible, and then keep that pipeline of innovation coming so that you've got exciting new solutions around cancer detection, diagnosis, stratification of patients. So we hopefully can do both things.
Brilliant. We are coming up towards the end of our time now. I don't know if you have any concluding remarks, anything you want to focus on, then now is the time to do that. Otherwise, I think I will invite people to engage with our report and give us feedback if you have such, and we can continue those conversations offline. So to round up then, I would just like to thank again both Claire and Catherine for joining us today. It's been really, really interesting talking to you, and the time has actually flown, and I could have asked you more questions and we could have carried on these conversations, I'm sure. But we are very much looking forward to hearing everyone's comments on our report, and we'll take feedback, and looking forward to talking to you at other events and in other forums in the near future. Thank you.